Hi, this is Sharon Smith, and this is my DNP Scholarly Project presentation on advanced care planning for young adults with high-risk cancer. This project is dedicated to Taylor and to all those who face the end of their lives too young. Also for my family, whose support and love has enabled me to pursue this journey. As an overview, I will be discussing the background and purpose of the project, a literature review, theoretical framework, the methods, analysis, and results of the project, as well as a summary and conclusion. In the United States, cancer is the leading disease-related cause of death in young adults, with approximately 10,000 cancer-related deaths each year. An adolescent with life-limiting cancer is faced with contradictory issues, being forced to look at the end of life in the midst of their own developmental challenges. The tasks at this age include trying out decision-making and working towards establishing one's identity and autonomy. Social support and communication with family, friends, healthcare providers, and other cancer patients is a primary coping strategy and is associated with positive outcomes for this population. So not respecting the decision-making ability of young adults can lead to poor communication and an increased distress for both the patient and the family. The essence of advanced care planning is communication about future health, including the end of life. Advanced care planning can also improve quality of life, autonomy, and self-determination. So the problem is that a diagnosis of high-risk cancer is a threat to one's autonomy and self-control. Advanced care planning preserves patient autonomy and enables a sense of self-determination and self-control, even at the end of life. However, adolescents and young adults are rarely offered the opportunity to participate in advanced care planning. So the purpose of this project was to use an advanced directive document as a guide to initiate communication about advanced care planning for young adults with life-limiting cancer in a simulated setting. The literature on pediatric advanced care planning is limited, but it has increased in the last 5 years. The recent Institute of Medicine report on dying in America recommends that advanced care planning communication occurs throughout the lifespan for all individuals, including children capable of participating, and that it is the clinician's responsibility to initiate these conversations. There is emerging evidence describing the benefits of using structured advanced care planning programs for young adults and for the completion of advanced directive documents. However, the strategies available to guide this communication remain limited. Though there are few structured programs for pediatric advanced care planning, the ones that exist are successful and are perceived as helpful to patients and caregivers. One such strategy is the FACE method. That stands for Family Adolescent-Centered Advanced Care Planning, and it is a model used in several randomized controlled trials by Lyon et al. And Garvey et al. This model involves 3 sessions that are 60 to 90 minutes long with the adolescent and their surrogate. This includes the Lyon Advanced Care Planning Survey, the Respecting Choices Advanced Care Planning Interview, which measures congruence of treatment preferences in a series of scenarios, and also the completion of the advanced directive document, the 5 Wishes. The FACE method has been described as beneficial, but it is time and resource intensive. FACE does offer, however, that using an advanced directive as a guide may circumvent some barriers to initiating end-of-life conversations. Similarly, qualitative descriptive studies have also been useful in content analysis of advanced directives and advanced care planning programs in pediatric populations. These offer insight regarding patient perspectives, concerns, and preferences. Young adults with life-limiting cancer have much to offer in defining what to include in advanced care planning conversations and what to include on advanced directive documents that will be meaningful to them. The only advanced care planning document for young adults and adolescents is called Voicing My Choices. Voicing My Choices was developed based on the 5 Wishes, a legal advance directive document for those over 18 that has been used by millions of adults. Feedback from participants aged 16 to 28 enabled the 5 Wishes to be modified to include preferences not only for medical decision making, but also how young people wish to be remembered. This Voicing My Choices was developed in the Wiener and Zade references and was also recently on the New York Times front page article in March of 2015. The process of advanced care planning is shown to improve quality of life at the end of life by increasing communication, social support, autonomy, and emotional well-being, and decreasing stress, anxiety, and depression. However, approaching these topics is challenging, and there is often discomfort on the part of the clinician as well as the patient and family. Issues such as fear of removing hope, lack of training, and timing are described as barriers to discussions about end of life. These conversations are not easy and are often avoided by both healthcare providers and families. They are even less likely to occur if the patient is not an adult. The literature on pediatric advanced care planning in recent years shows that this communication does not result in distress or negative effects on psychological well-being and is helpful to patients and caregivers. The literature on nursing and nurse practitioner education in the area of palliative care and advanced care planning communication indicates that educational offerings are very limited. One method for improving clinician exposure to advanced care planning with young adults is to offer simulated learning with standardized patients. Although simulated learning cannot replace real-life experience, it has been shown to increase comfort level and improve communication skills surrounding difficult conversations like advanced care planning. The use of standardized patients allows the clinician to practice communication skills. In addition, the clinician is provided the opportunity for self-reflection and receives multiple sources of feedback from the patient, peers, and facilitators. The learner develops competence as well as confidence and communication required for difficult conversations in a safe environment. In addition, the use of an advanced directive document provides a structure to guide this conversation. Using these strategies together may decrease the barriers to advanced care planning with young adults by increasing clinician competence and comfort. I used the advanced directive decision-making model from Goodwin, Keel, and Patterson. This model is based on Imogene King's conceptual system and mid-range theory of goal attainment. In King's theory, goal attainment involves an interactional collaboration process that relies on communication to achieve mutual goals and satisfaction. In the advanced directive decision-making model shown here, the nurse and the patient are viewed as equals, with decision-making occurring through the interaction and involving both the nurse and patient making choices. The patient is making end-of-life choices, and the nurse is deciding how to educate and advocate for the patient. Timing, type of discussion, decision-making, and communication are negotiated based on mutual goals. The goal of the advanced directive decision-making model is self-determination, where even an inaction is viewed as an action of self-determination. Mutual goal attainment is achieved when the nurse educates and empowers the patient, and the patient experiences autonomy through self-determination. This project is evidence-based and was developed to evaluate the use of an advanced directive document as a guide to initiate communication about advanced care planning with standardized young adult patients in a simulated clinical setting. The methods used were a pre-test, post-test, non-experimental design to describe nurse-provider confidence and attitudes towards advanced care planning, as well as satisfaction with the use of the voicing my choices to introduce advanced care planning within the simulated experience. Participants were nurse providers who care for children, adolescents, and young adults with life-limiting conditions, and who volunteered to take part in this project. Due to limited capacity in the simulation lab, a maximum of 18 nurse providers were recruited from a convenient sample of practicing nurses, nurse practitioners, and nurse practitioner students from a large metropolitan teaching hospital. The DNP student was the project leader. Correspondence included an electronic announcement of the project and a description of the procedures required. Informed consent was implied by the participants' response and agreement to complete the pre-simulation readings and questionnaires prior to and following the simulation. There were no consequences for participants who chose not to attend the simulation or complete the questionnaires. Participation was completely voluntary. The project was implemented in the Clinical Education and Evaluation Laboratory of the University of Maryland, Baltimore. Hospital nurses could easily walk across the street to the lab. The simulation case was developed by the project leader based on personal clinical experience and was reviewed by 2 content experts for content validity. Prior to the simulation, the participants completed pre-readings in order to be familiar with the case and to have some background knowledge of the Voicing My Choices document. Upon arrival for the simulation session, participants completed the pre-simulation questionnaire. Then a pre-briefing was held with the group to establish guidelines for confidentiality surrounding the simulation, and a review of the case as well as the specific role of the standardized patient was given. The pre-briefing session took about 5 to 10 minutes. Each simulation session took 45 to 50 minutes, including the pre and post sessions, and consisted of 1 to 2 participants and the standardized patient in the simulation room. This time frame was developed from previous evidence as well as similar simulation cases performed in the Clinical Education and Evaluation Lab using standardized patients. The project leader and the simulation instructor viewed the activity through an electronic recording of learning space and used the Smarter tool to score targeted responses of the nurse providers. The Smarter approach has demonstrated validity and reliability in the clinical setting and was used here to provide feedback to participants during debriefing. At the end of the simulation session, participants completed the post-simulation questionnaire and a debriefing session occurred. In the debriefing session was the project leader, the standardized patient, the simulation instructor, and the student participants. This took approximately 5 to 10 minutes. The measurement instruments are included in your handout. As previously stated, participants were given a questionnaire pre and post simulation. These questionnaires were developed through review of the literature and have been reviewed by 2 content experts for content validity. These are Likert-type questionnaires and were designed to evaluate prior experience with advanced care planning, attitude towards advanced care planning in young adults, confidence in discussing advanced care planning, and satisfaction with the use of the Voicing My Choices and with the simulated experience. The pre-simulation questionnaire contained 18 items, and the post-simulation questionnaire contained 22. 5 items assessed attitudes toward advanced care planning, and 4 items assessed self-confidence in advanced care planning that were duplicated on both the pre- and post-simulation questionnaires. The Voicing My Choices document is available from the Aging with Dignity website and is copyright protected. It is reproduced in this handout with permission. In this simulation, participants initiated advanced care planning communication with a young adult using the Voicing My Choices document. The Voicing My Choices has established content validity and is presented in a format and appearance that was deemed preferable to young adults and adolescents. It is not legally binding, but it has been recognized as helpful in initiating end-of-life discussions and in elucidating the wishes of adolescents and young adults surrounding their decisions and preferences. The Voicing My Choices is a booklet that has 16 pages, including the cover. There is a description about how the booklet was developed, that the topics may be difficult, that the booklet can be completed as much or as little as desired, and that there are no right or wrong answers. The introduction also encourages the participant to use the glossary provided, as well as to discuss questions with their healthcare provider. Content sections include both structured items or checkboxes labeled My Choice, as well as open-ended sections labeled My Voice. There's a final section called My Voice that is a blank section for personal messages. Following the simulation, there was a debriefing session that involved participants' self-reflection and feedback from the standardized patient, peers, the project leader, and the simulation facilitator, including a review of the Smarter tool. The debriefing included open-ended questions to participants about their feeling in the simulation, about how they perceived their performance in the simulation, and what, if anything, they would have done differently. Facilitated debriefing has been described as a critical component of the simulation experience, as it provides an opportunity for reflective learning. This project represented minimal risk to subjects. The potential benefits included an increase in clinician comfort level and improved communication skills surrounding difficult conversations like advanced care planning. Participants were provided the opportunity to practice communication skills without exposing patients to undue harms. In addition, the participants had an opportunity for self-reflection and to receive multiple sources of feedback from the patient, peers, and facilitators. Participation was voluntary, and nurse providers could withdraw at any time. The simulation faculty were available to coach participants who may have been uncomfortable in the simulation, but that did not occur. All reasonable efforts were made to ensure confidentiality. The simulation was performed in a private setting, and the number of providers was limited to the project leader, the standardized patient, the simulation instructor, and the nurse provider participants. All questionnaires were coded with a self-generated 4-digit code in order to prepare the pre- and post data. Data collection instruments were kept in a locked box for transport between the setting and the project leader's office. Data were kept in a locked drawer, in a locked box, in a locked office. Video recordings of the simulation were password protected. Data entered into computer programs for analysis were de-identified, and data presented will not be identifiable. The project was reviewed by the IRB at the University of Maryland School of Nursing and was considered exempt as there were minimal risk to participants. Descriptive statistics were used to display participant demographics. Paired t-tests were used to assess the differences between responses on the pre- and post-simulation questionnaires. The data was evaluated for change in self-reported attitudes and confidence of participants towards advanced care planning communication with young adults. In addition, level of satisfaction with the use of the Voicing My Choices to introduce advanced care planning and with the simulation experience are reported. The results. The sample consisted of 18 nurses who were all practicing nurse clinicians, either as nurse practitioners or as nurses in the process of completing their nurse practitioner degree. All were female. 56% were younger than age 30, and 78% had 10 or less years of nursing experience. 61% were employed in pediatrics and 22% in the pediatric intensive care unit. Only 2 nurses in the sample had prior training in advanced care planning, and this consisted of a single module in the End of Life Nursing Education Consortium, or LNEC, training program. Approximately half had participated in an advanced care planning conversation, but only 4 had done so with someone younger than age 18. And only 3 nurses in the sample had participated in completing an advanced directive. This table represents the results of the pre-simulation and post-simulation assessment of attitudes and self-confidence in advanced care planning. The starred items on the last column are statistically significant. Most participants recognized their own responsibility as a provider to initiate advanced care planning. However, this response was significantly stronger on the post-simulation evaluation. That was at p less than 0.03. There was no significant difference in the assessment of whether it was someone else's responsibility to initiate these conversations. Participants agreed that the best time to have advanced care planning conversations is early in the disease process, and that this conversation should not wait until a later time or at a time of relapse. These findings were not significantly different on the pre versus post-simulation assessment. Before the simulation, participants agreed that advanced care planning should be presented to all patients capable of participating, regardless of age. But following the simulation experience, they agreed significantly more strongly that advanced care planning participation is not age dependent, and that was significant at p less than 0.01. But perhaps the most importantly are the findings that each measure of self-confidence in advanced care planning significantly increased following the simulation, and that is represented here in the last 4 rows. These include comfort in their ability to initiate advanced care planning in the practice setting, confidence in their ability to discuss advanced care planning, confidence in their ability to discuss advanced care planning with patients under the age of 18, and an acknowledgement that they possess the skills needed to have an advanced care planning discussion. There was an overwhelmingly positive response to this simulation activity. This table represents the results of the assessment of satisfaction with the simulation, where 5 would equal strongly agree on the Likert scale. The simulation was useful and valuable to the nurses sampled. It increased their awareness and allowed them to practice advanced care planning communication in a safe, non-threatening environment. The Voicing My Choices guide was described as helpful, well-worded, and user-friendly. Comments from the participants in the debriefing sessions and following the simulation indicated that the nurses felt the advanced care planning simulation was a great opportunity, and the Voicing My Choices document was useful in guiding the conversation. Participants felt that the simulation should be held routinely and that advanced care planning should be a regular part of conversations with patients, rather than becoming the elephant in the room. The limitations of this project include the use of a convenience sample, which limits the generalizability of these results. Using a sample from one institution does not allow one to extrapolate to all populations, as this institution may not be representative. Also, pediatric nurses are not the only nurse provider population, and there may exist unidentified intrinsic factors that may have skewed the results. Further research in this area should involve a larger, more diverse sample. In summary, advanced care planning is an important and too frequently missing step in the care of young adults with life-limiting conditions. There is evidence to support the recommendation that clinicians routinely provide advanced care planning to young adults. However, few nurse providers have had training or experience in having these difficult conversations. Offering a simulated learning environment enables the learner to develop competence as well as confidence and communication skills required for difficult conversations like advanced care planning. In this project, the majority of nurses had no prior training in advanced care planning. However, following a 45 to 50-minute simulation exercise, these nurses expressed significant increases in self-confidence and skills, not only to discuss advanced care planning, but to initiate the conversation. In addition, nurse providers felt it was beneficial to use an advanced care planning tool, such as Voicing My Choices, as a guide to structure this conversation. The response to this simulation was overwhelmingly positive, and participants expressed that advanced care planning instruction is lacking in nursing programs. The literature on nursing and nurse practitioner education in the area of palliative care and advanced care planning communication supports that educational offerings are limited. There is a tremendous need for advanced care planning to become part of every patient encounter, no matter the age of the patient or state of disease. In order to accomplish this, nursing education programs must implement training such as this simulation program. Plans for this completed project include sharing the information with stakeholders here at the University of Maryland to determine a need for a change in educational preparation surrounding advanced care planning in young adults. This information may also be shared at a professional conference or within a professional journal. However, no link to the organization or participants would be specified. The dissemination and translation into practice message here is that clinicians should routinely provide advanced care planning to young adults with life-limiting illness, and they need to be trained how to do so. Ultimately, advanced care planning should become part of every patient encounter, no matter the age of the patient or state of disease. I included the references at the end of the handout, and I thank you so much for your attention. If there's any questions or comments, I will take those now. I would also like to acknowledge my scholarly project chair, Kathy Hott, and my committee member, Debbie LaFond, for their support and guidance in this project. Thank you.